all around. So malignant growths will have a halo, a black halo all around. Look at this as well. There you see multiple metastatic deposit, and each is surrounded by a black zone. So malignant growths, they have these black infiltrating halos around. It is difficult at times to see the halo around a malignant growth. So in those situations, we must keep this in mind that we should not increase the gain of the brightness, the density, intensity of the beam to such an extent that the halo become obscured by the increased brightness. If you closely look at this very small bright nodule, which is malignant, it also is surrounded by a black halo. This tumor is again surrounded by a black halo. Halo is a sign of invasion and infiltration, and it is seen around malignant deposits. I will take you now to show you how this black you can see here, the bright nodule surrounded by black halo. This is how we see malignant deposits. But do we see any halo around this lesion? No, there is no black halo. This is how a benign capillary hemangioma will appear. A benign capillary hemangioma is, is very bright, but without any black halo around. While here you see the clear cut halo around. Look at this, shower metastatic deposits, shower mets in the liver. Each one is surrounded by a black halo. So this is how malignant deposits, they are seen infiltrating the surrounding liver parenchyma. Here again, you can see the halo. Again, see the halo. And look at this halo, a huge mass, multiple masses. A kidney, bean-shaped structure seen behind the liver with its dark gray parenchyma. and bright pelvic system inside. The longest dimension from the upper to the lower pole and the width of the kidney, you can see the parenchymal thickness is this. This kidney appears black because the liver on top is a fatty liver, allowing very little ultrasound waves for us to see the kidney. This kidney is brighter than the liver, while this kidney is darker than the liver. The normal hepatorenal contrast is such that renal parenchyma is a little darker than the liver. Renal parenchyma is a little darker than the liver. But here you see, in this condition of renal parenchymal disease, chronic renal parenchymal disease, this renal parenchyma is brighter than the liver on top. So this kidney is diseased. You can see the liver there, the dome of the diaphragm, bright fibrous dome, and above the dome you can also see some pleural effusion because of this renal problem. All right, so now we will show you some images on our videos. There we see the outline of the kidney, and usually in the left kidney, we find a hump here in the middle pole called dromedary hump. It is because during intrauterine life, the spleen keeps on pressing upon the upper pole of the kidney, the left kidney, and the parenchyma is pushed towards the middle of the kidney where it produces a hump. So this hump or a bump is seen on the renal surface, which is called dromedary hump, a hump of a camel. This is how it appears and should not be confused with any growth, which we do it on Doppler. You can see that in this hump, the vessels, they are going straight. But if it were a malignant growth, then you will see the vessels growing wayward, right or left. They won't be going straight in it if it were a, a tumor. So this is how we see a dromedary hump. Dromedary hump, Dromedary, on the middle pole. So this was a normal anatomical variation. Here in this kidney, we can appreciate that the central bright pelvic system is a little dilated. You can appreciate the urine in the pelvic system, and these are dilated because of this bright stone impacted in the renal pelvis. This is how we see the mildly hydronephrotic kidney due to impacted stone in the renal pelvis. You can even appreciate the shadow behind. There you see the shadow behind the stone. This is how it appears. So a stone in the renal pelvis. Look at the dilated calyceal system. So many calyces, all draining into the pelvis. They're all mild to moderately dilated. And there you see the parenchyma. Within the parenchyma, you can appreciate black pyramids, which are in fact loops of Henle. So the calyces are here with bright white walls, and in the parenchyma, if you look carefully, these are the calyces with white walls, and this is the parenchyma with renal pyramids, part of the renal medulla. There you see the renal pyramids inside. All are aligned in one line like this, all around the pelvic system. These are the loops of Henle, these renal pyramids. And glomeruli, they are the rest of the renal cortex. So calyces with white walls, pyramids without any walls, and cortex, the glomeruli, all around and in between the pyramids. This is how the renal anatomy we see. Look at the pyramids, look at the calyces. That is definitely dilatation, mild hydronephrosis because of some ureteric obstruction. You can see the pelvis, and I would like to show you how this pelvis is going into the ureter. This is the ureter, which you can see the pelvis, and there you see the ureter going down. This is the ureter going down, right. This is moderate to severe hydronephrosis. You can see markedly dilated upper, middle, lower pole calyx, markedly dilated renal pelvis due to this stone, which is impacted in the at the pelviureteric junction. This stone is impacted at the pelviureteric junction. And you can see the kidney with dilated calyces, all draining into the pelvis, and pelvis is obstructed because of a stone there at the pelviureteric junction. Kidney, renal parenchyma here is all right, but when we go up, you can see it's all distorted. This gray, dark gray parenchyma is distorted here because of this fleshy growth, a huge fleshy growth in the upper pole. This is how a renal tumor will appear, a huge renal tumor in the upper pole. And many a times you will see them growing silently. Most of my trainees, they have diagnosed this condition when the tumors, they were growing absolutely silently. So there you see the lower pole of the kidney is supplied by the renal vessels, but here this is the tumorous upper pole. Right. Here, check कर This is a cross section of the urinary bladder. Huh. This is a cross section of the urinary bladder. We can appreciate on the posterior wall here, this is all urine. You can see two humps, one on the right and another on the left side, bulging into the bladder. This, my dear, is the interstitial part of the ureters passing through the wall of the bladder, and here they are opening up. Here they are opening in the on the posterior wall. Behind you can see the black tubes of seminal vesicles, the right and the left. This is right, this is left. So this is the right ureter opening into the bladder. This is how the ureteric distal vesico-ureteric ends are seen. Now here, this is the bladder. You can see a dilated ureter because there is a big date-shaped stone impacted in its distal, and it's an old stone which is developing as a date-shaped ureteric calculus at the distal end of the ureter. It is right or left that we will decide on the cross section. There you see the bladder on cross section. You can see the left ureter here with the stone, and there you see its inner end. And there you see the left ureter. This is how we will see the dilated ureter and the stone with the shadow. Now, is this in this image, the distal end of the right ureter is herniating. The ureter is herniating into the bladder like a balloon. Herniation of the distal end of the right ureter in the bladder here is seen, which is herniating into the bladder as a balloon. There we are. There you see. And here, impacted in the neck of this balloon, is a calculus producing a shadow. A clear cut shadow can be seen. There we are. A stone impacted here in the neck of this balloon, producing a shadow. And this is the herniating distal end of the ureter into the bladder. This is called ureteric hernia or ureterocele. Ureterocele. Usually, it leads to recurrent urinary tract infection and stone formation. Urinary bladder can be seen here in a female patient. As we can see, the vaginal lumen and the uterus and cervix. There you see the bladder. Look at the posterior bladder wall. It is elevated, the right and the left ureteric ends. So the bladder wall here is edematous and elevated because of inflamed trigonal area, trigone of the urinary bladder, this one. So this is inflammation of the trigone area. So when I put color, I can see, oh, the gush of urine coming out from the right ureter. This is how we can appreciate the ureter producing gush of urine out from the ureteric, distal ureteric end. This is it, the urinary gush. So now we will wait for the azan, and then we, after the azan, we will continue. For another 10 minutes, and then we will have um, the Juma prayer break and lunch break. We will continue afterwards. We will be seeing some more interesting images, and then we will be having a probe handling session in which I will be showing you the techniques of probe handling and a little bit of nobology. These informations which we are providing today is just to introduce to you that sometimes there, and if we consider, there, alhamdulillah, always is a blessing in different tests which we are put are put to during our life, uh, like this corona test which we are going through. So the blessing is that you will be astonished to see how conveniently this training can be given. And I am fascinated by the excellent results which we are having so far of our two training programs, which we already have started, a basic and advanced training, both. So, whenever we come across a patient who has got painless hematuria and we are suspecting some growth in the bladder, that growth will appear as a polypoidal lesion projecting itself into the bladder, as you can see here, from the posterior and left lateral wall. This growth is projecting into the bladder, and it is in fact covering the left ureter as well, and it was producing mild left hydronephrosis and hydroureter. This growth, invariably, when we put color on it, invariably it will appear very, very vascular. So we will show you in a moment how this growth will appear. There you see the blood flow within the growth. And these patients, they usually either present with painless hematuria or just incidentally we find this growth projecting itself into the bladder, and patient, they had no problem, no complaints whatsoever. This is how a growth will appear. This is going to be the last collection of videos for you regarding ovaries, in which we will see how the ovaries will appear with maturing follicles, immature follicles, chocolate cyst, carcinoma of the ovary, and a dermoid cyst. So let's start from the ovary. There we are, the urinary bladder. मुनीर से पूछें आ रहा है. You see the bladder here, the uterus here. This is the left ovary, and this is the right ovary. And you can see some black spots inside. I magnified for you. You can see some black spots inside. These are the immature follicles, small, immature antral follicles. There you see, small, immature antral follicles. This patient who was given clomiphene citrate, we can see here that some of the follicles, they are a little prominent. You can see the uterus with its typical triple layer appearance. There we are. The triple layer appearance of the uterus, uterine endometrium. It will appear like this. This is the triple layer appearance. A patient who is going to ovulate in the mid-cycle, peri-ovulatory endometrium is like this. The central luminal line. On both sides, these black zones on both sides of the luminal line are the superficial layers of the endometrium, which are full of fructose filled secretions. And there you see the bright endometrium peripherally located. So, in the mid cycle, peri-ovulatory triple layer, how are we going to take this as triple? This is endometrium, this is lumen, this is the other endometrium of the opposite wall. Anterior wall endometrium, lumen, posterior wall endometrium. So all are three. In between are zones of fructose filled glands, which you can see. Triple layer. And we see this when there is ovulation taking place. Whenever a follicle ruptures, there will be around 6 cc of free fluid um, seen in the pelvis, which I will show you in a moment. This was the follicle which ruptured. Now its walls are collapsed. There you see collapsed walls. Hmm. And this is the right ovary without any maturing follicle. So a 2.5 centimeter diameter follicle which ruptures is usually, um, there you see some fluid. This is some free fluid here as well as here. There it is. Some free fluid here, some free fluid here. There you see the fluid. This is it. So, this free fluid, because of the rupture of the Graafian follicle, the fluid comes out, the follicular fluid, and in 6 to 8 hours, it will disappear. So, a maturing follicle. This ovary has got multiple immature follicles. 1, 2, 3, 4, 5, 6, 7, 8, 9, and none is growing bigger than 10 mm. This is how we find the polycystic and ovulatory ovaries full of immature follicles. And this condition you will see in both ovaries. The ovarian flow of a polycystic ovaries is strong forward diastolic flow. The endometriotic cyst in the pelvis will appear like sand. It will give the appearance of sandpaper like appearance. As you can see here, this is a chocolate cyst, this one, an endometriotic cyst. And here you see adjacent to it a hemorrhagic cyst with lacy fibrin septas inside. These are the lacy fibrin septas. This is the chocolate cyst, full of altered blood. Altered blood. And this is a hemorrhagic cyst adjacent to it, just an incidental finding. So this is how. And there you see the uterus with endometrium. So it looks solid, but there always is posterior wall brightness, which will make the life easy for us to confirm that we are dealing with a chocolate cyst. Now, here is a malignant ovarian cyst with fleshy, polypoidal, or fleshy septas. You can see the fleshy septas adjacent to the ovarian wall, and we always put color. We always will put color on top to see if this growth is vascular, if these septas are vascular or not. If they are, it will be taken as potentially neoplastic. Here you see the markedly thickened, fleshy, polypoidal lesion on the posterior wall, and the septas inside are also considered as solid element, fleshy septa. So we always will put color. You can appreciate now. There it is. The septas are carrying blood vessels. This is the fleshy growth, and there you see the septa carrying blood vessels. A polypoidal growth with blood vessels inside is potentially malignant. There you see an ovarian cyst with multiple fleshy polypoidal lesions inside, and there is very little effusion left behind. Very little fluid of the cyst, and mostly it is the polypoidal lesion filling the tummy of the ovarian cyst. So the more we see the fleshy polypoidal growth bulging into the cyst lumen, the more are the chances of anaplasia, poorly differentiated ovarian cyst. Well, malignant it is because of these polypoidal growth, but how severe and how much poorly differentiated is this ovarian cyst will be determined by the ratio of solid component, this fleshy solid component, and the cystic component. if the solid to cystic ratio is disturbed, more solid, less fluid compared to other ovarian cysts and compared to your experience, if we see more fleshy component bulging into the ovarian cyst, human will take that as severely or poorly differentiated. So, severe malignancy or poorly differentiated ovarian carcinoma. How is a dermoid different from an ovarian cyst? We'll find other ovarian cysts. We'll find in a dermoid sebaceous material floating in the cystic medium. So this is how we say that a dermoid will give us a paradoxical appearance against truth. It is not a truthful appearance, that solid, which should normally settle down on the posterior wall, is floating on top of cystic. So this is the paradox, the paradoxical appearance of an ovarian, malignant ovarian cyst, in which you will see the the sebaceous material, the fat floating on top of the cystic sweat. Remember that, like the oil floating on a curry or oil floating on a soup, the sebaceous material, which is oily, has got less specific gravity compared to the water inside the cyst. So therefore, because of less specific gravity, sebaceous material will float on top of the this cystic fluid inside an ovarian cyst, because it is all made up of fat. So this is paradoxical appearance of the dermoid, that solid is floating on cystic. And within this solid looking sebaceous material, you can also appreciate a solid reflecting surface producing a shadow. This is two hair balls, one and one. Two hair balls made up of bone or teeth inside will appear as they are appearing here in a dermoid. As we all know, that dermoids are totipotent. So we'll have sweat, we'll have sebaceous material of the skin, we'll have hair, we'll have the skin, we'll have the teeth or bone particles inside, which can be seen on plain X-ray. But ultrasound is one of the modalities of choice. So now we will meet again at 2:30 p.m. after the Friday prayers and the lunch break at 2:30 p.m. Our link will remain open. We'll pause it, but you can stay connected to us during this session, during this break, and afterwards we will continue. It will make life easy for both of us. So thank you very much. Wassalam wa rahmatullahi wa barakatuh. Stay connected, please. Don't go away. We are not going to close the computer.